Welcome back to another lifelong nursing video. I'm Brent. I'm an acute care internal medicine nurse practitioner, and I'd like to talk to you about something that's recently become my biggest pet peeve. So grab a pen, take notes. So first of all, this video is about, is this a medication allergy or is this a medication side effect? And I'll tell you why that's important, because people that list these side effects as allergies cause real complications with some of these medications that we're trying to prescribe them, whether inside the hospital or outside the hospital, that they otherwise may take a less complicated medication but end up on the more expensive or more complicated, more side effect medication because of this GI upset or makes me feel sleepy or stomach ache. So we really need to be educating these patients. That's a side effect. We can treat your side effect. That's not a true allergy. Let's take that off your allergy list. So just some of the things I have here are a few examples, but first I want to get into actually the research on what the allergy research says. So according to the American Academy of Allergy, Asthma, and Immunology, only 5 to 10% of people that have adverse drug reactions is really a true allergy. That's things like hives, shortness of breath, wheezing, swelling, anaphylactic shock, that sort of thing. So just 5 to 10% of the American population have a true drug allergy that we really do not want to give them or avoid giving them at all costs. But sometimes that's necessary to be giving, and we can sort of give Benadryl, steroids, H2 blockers to try and reduce that true allergy. So let's get right into this. So first and foremost is probably the most common things, people that say, I'm allergic to penicillin. Okay. Well, I deal mostly with adult patients, very rarely in their 20s, sometimes in their 30s, more commonly in their 40s, 50s, 60s, 70s, all the way up to 100, even above 100. But the most common patients I get that have an allergy are penicillin allergies. And I'll say, what's your allergy to penicillin? I don't know. Or, it gives me a rash. Or, I was just told not to take penicillin. Well, when were you diagnosed with this penicillin allergy? Back in childhood. Or, I'm not sure. These are important things to know and really find out from your patient if you can. I understand that all patients you're not going to be able to find that information from. They're going to be confused. They're going to be elderly and demented, or traumatic brain injury patients. They're aphakic, can't speak. MR patients, or patients that have caregivers that have only been caregivers for the short-term period in their life and they don't know their true background. So I understand that part, but when we can really assess these patients and ask them, when were you diagnosed with a penicillin allergy? And they say childhood, ask them what that response is. If it's GI upset, or abdominal pain, or stomach ache, nausea, that sort of thing, we really need to say, is this a true allergy? Because a lot of the antibiotics we give, as some of you know, are penicillin derivatives. For example, cephalosporins. Just some research I have here, and this is a little bit contested, but not contested, but still trying to be worked out in research because there's not a lot of research on it. But people that have a true penicillin allergy are actually, or claim to have a true penicillin allergy, are 10% of the population. When we look at the research, just 10% of that 10%, so really 1% of the population, if I'm doing my math right, and my internet math, has a true penicillin allergy. We're talking anaphylactic shock, wheezing, severe abdominal cramps, worrying about ischemia, that sort of thing. So these people are the ones we need to be labeling as a true penicillin allergy. The reason I bring that up is because 90% of those 10% of people in the U.S. population don't actually have a true penicillin allergy, or they grow out of it, or may never have had that in the first place. So the reason I bring that up is because if in the hospital, as we get more and more drug-resistant bugs and bacterial infections, we're leaning on the highest and most empiric antibiotic, and sometimes the most expensive antibiotic for these people that otherwise we could sort of taper back. So people that have a penicillin allergy and it says unknown or GI upset or rash, that doesn't give us a whole lot of information. So that kind of limits us on what we can do. So let's say somebody has healthcare acquired pneumonia, which there'll be a video up later on this channel about what qualifies for healthcare acquired pneumonia and how to treat it. But let's say somebody comes in, we diagnose them with healthcare acquired pneumonia. Well, depending on the different antibiograms, primarily we're going to place them on IV vancomycin, IV cefepime, or something like IV Zosyn. Now, IV Zosyn, its generic name is Piperacillin tazobactam, and it's a 2-part medication. Both of those parts are actually penicillin derivatives. So given that that's a cephalosporin, a derivative of penicillin, so if they have a penicillin allergy, the pharmacists or the other physicians or nurse practitioners, PAs, you name it, they're going to question, should we be given Zosyn in the first place? Is there another medication that we can give, such as Levaquin or ciprofloxacin, that can treat this medication? But do we even need to go that far anyway? So let's think about this. Somebody with a penicillin allergy 20 years ago that doesn't know their reaction, that were given a penicillin derivative, the research shows that we can give that and give it very safely. Less than, and straight from the Zosyn manufacturer website, the Piperacillin tazobactam website, straight from their manufacturer website, less than 1%, less than 1% of the American population, or people that receive this drug, less than 1% of them have a true anaphylactic shock. So primarily in the world of healthcare, someone that has a penicillin allergy that's not otherwise listed as anaphylactic shock, the side effects, GI upset, abdominal pain, nausea, we need to be given the cephalosporin. We don't need to be holding it and given Levaquin or Cipro or another drug. We need to be given the penicillin drug because the research shows that it's highly safe. The research shows that they may not even have a true penicillin allergy anyway. So I think that we need to be more reliant on ourselves and more thorough when we're doing our histories and physicals, or when the intake nurse or the admission nurse is bringing in these patients and going over the allergies of the patients, and they say, hey, I have a penicillin allergy, instead of just marking it down and say, oh, what was your reaction? Oh, I had a rash. Okay, had a rash. Ask them, where was the rash? How serious was the rash? Was it on your arm, hand? Was it just localized in the IV site? Did you take penicillin by mouth and have a total body rash? Is this rash associated with shortness of breath, wheezing? Did you have to be put on a breathing machine? These are the things that, especially antibiotics, that we need as practitioners, healthcare providers, nurses, pharmacists, pharmacy technicians, when they do the med recs at some facilities. We need to be asking them, especially on the antibiotics. I cannot stress this enough. What was your reaction? How did you react to it? How long was it ago? Have you had it again? Was this a one-time thing or was it repeated? That sort of thing, so we can get more information than just a rash. Now, So that's one of my biggest pet peeves. Just for an example, I was admitting a patient from the emergency room a couple of weeks ago. She had 3 to 4 days of shortness of breath, wheezing, didn't really have much of a COPD history. She didn't really smoke, never went to a lung doctor. So and had high fevers. So and had a sore throat. So, initially, like we all do, when we have a sore throat, we kind of just wait around, see how we do. If we get better, get worse. So this lady was worsening very slowly. It wasn't like an acute onset shortness of breath and made her come to the hospital. So by the time I've seen her in the emergency room, she says, I heard this whistling when I breathe from my throat, not from my lungs. It feels like I'm swallowing a golf ball. My tongue's super enlarged. When I tried to look at the back of her throat, we have the tongue depressor, the little popsicle stick, actually broke one of those popsicle sticks, one of those tongue depressors, trying to depress her tongue to look in the back of her throat. That's how swollen her tongue was. Well, what she ended up having, I got a lateral X-ray, a soft tissue X-ray of her neck, and she ended up having epiglottitis, inflammation and infection of the flap of skin that protects your trachea. So when that's infected, you're going to have sort of a life-threatening infection, and sometimes people aren't caught in time, and they do die. Sometimes people need to be put on a breathing machine, less so than others. But the fact that this lady had epiglottitis, and she had a penicillin allergy, and that penicillin allergy was a rash. Now, this lady wasn't the best historian, so I couldn't necessarily clarify her rash. She said it was years ago, that she doesn't even remember when the diagnosis was given to her. She just knows that she couldn't take penicillin because of a rash. You're going to encounter these things in the healthcare process, but it's important because I wanted to, based on my hospital's antibiogram, we needed to treat her with cefepime or Zosyn. So I would like to give her cefepime. She has this penicillin reaction. Again, it's safe enough to give based on research, but I get kickback from other physician, my attending physician, or pharmacy, saying, hey, she's got a rash. That's not a true allergy, we know. So let's don't give that. And I agreed, because the patient had a swelling tongue. And if she ended up having an anaphylactic reaction to the Zosyn or cefepime, we wouldn't want to unnecessarily complicate that. So that's an extreme example. But when people have like cellulitis, their finger, their leg, stomach, and they have this penicillin allergy, primarily it's safe to give your cephalosporins, not only in a small chance of cross-reactivity, but do they really even have an anaphylactic or a true penicillin allergy in the first place, especially if it's in childhood, especially if it's listed as a rash. GI upset, well, even a rash, GI upset, stomach ache. I was told not to take penicillin. These people, if they're alert and oriented, are going to remember, hey, I had an anaphylactic shock. I almost lost my life. And I have met patients like that, and I did document that in the allergy list. I said, hey, patient, had an anaphylactic reaction. So it's important to clarify how these patients react to these allergies, especially if you're the first person seeing them. So one of my pet peeves is just putting down an allergy that's a side effect with no clarification. Because if you can do it, these people, they're early in life. They say, hey, I have an allergy to aspirin. I can't take aspirin. GI upset, GI bleeding, whatever the case may be. If you just put GI upset with aspirin, and then but not put down GI bleeding or causes bleeding, 10, 15 years down the road, something can happen where they're no longer within their right mind to be able to describe that true allergy. That allergy is going to be sitting there in that medical record with no clarification, no real way or ability to clarify that. And so if they have a heart attack at this stage, or an NSTEMI, or acute coronary syndrome, of course we're not going to hold aspirin for a GI upset, and potentially really not GI bleeding either. But long term, from a heart score standpoint, those patients need to be on aspirin. Now there's research saying that aspirin may not be beneficial, but that's just one example. So let's move on, kind of go on a little bit on that. So other common side effects I see are diarrhea. Let the patients know that that's not a true allergy. We can give them medications that treat their diarrhea. So if they're worried about getting an antibiotic, amoxicillin, that gives me diarrhea, I'll tell you up front. It gives a lot of people diarrhea. But if you're on amoxicillin for pneumonia, patient pneumonia, or ear infections, things of that nature, don't say, hey, I've got an allergy to amoxicillin, it makes me have severe diarrhea. No, just let the healthcare provider know you have diarrhea, but Imodium helps, or taking probiotic helps, that sort of thing. We need to really get in and dig our fingers in when we're assessing these patients, especially for the first time, and educating them. That's not an allergy. That's a common side effect. We can treat that side effect, okay? All right, moving on. What are true allergies? Rash, of course, hives, swelling, wheezing, difficulty breathing, tachycardia, palpitations, anaphylactic shock, most people are familiar with. But again, as I mentioned earlier, when you see an allergy that says rash, elaborate. Is this hives? Is this full body rash with shortness of breath? Is it a neck rash, facial rash? Is it a rash on their foot? Let's clarify. And just a side note, a lot of people, when they have allergic reactions, true allergic reactions, they can take the drug once or twice, and then go a while and not have an allergy, and then you give it to them again. That's when they're going to have the allergic reaction, and then they're going to say, well, I've taken it before, and it didn't happen. Well, the body was building up a defense against that, and then it showed itself the next time they got it. So just word to the wise there. But when they have something generic, and it really seems to be a true allergy, please get them to elaborate. Please comment in that elaboration. Don't just put rash. That does not help us as healthcare providers. That does not help us as a pharmacist or a nurse. You really, really should do a better job of assessing and really broadening that out. So that's just step one, sort of the lowest kind of concern on our true allergic reactions. Another common ones I see that doesn't really have a lot of clarifications is swelling. They'll just say swelling. Swelling where? Is it at the IV site? Is it swelling on their legs? Is it swelling in their stomach? Is it swelling in their arm? Is it periorbital swelling? Is it tongue swelling? We really need to know where the swelling is, because, drugs like calcium channel blockers, they'll cause swelling. That's not an allergy. That's sort of a side effect. But it could be swelling, and it'd be a true allergy if it's anaphylactic in nature, or a true IgE-mediated reaction. So even if you're not admitting the patient for the first time, you're just taking over for the nurse, or taking over for another physician or nurse practitioner or PA, and you see these allergies, you can step up and ask the patient to clarify that. We can clarify at any stage of the game as long as the patient are able to. So I think we should be on that, every patient, and take the time to really describe what these allergies are. Excuse me. So another one, tachycardia. Did you have palpitations? Did you have a heart attack? Were you short of breath? That sort of thing. You need to put these in the comments. Now, I'm almost done, but so that's clarify. I cannot speak to that enough. And when I was a floor nurse, I'm guilty. When I was a floor nurse, I was a floor nurse for 6 years, ICU mostly, different facilities. I thought I was doing a great job. Hey, what's your allergies? It's a rash, this and that. But I didn't clarify. And now that I'm sort of on the other side and I'm really having to gauge these allergies critically, because I'm responsible for ordering these medications, it's very, very important from all steps, again, from pharmacy technician to the nurse practitioner, PA, physician, pharmacist, to really pay attention and see what these allergic reactions truly are. Last point. I've seen a lot of this. This is an even bigger pet peeve than people putting side effects as allergies. So it is leaving a medication on the allergy list and then putting in the comments, hey, they tolerated it back in 2017. They did fine with Zosyn, but they got a penicillin allergy. They did fine with Zosyn or a Zosyn allergy. They tolerated Zosyn 2018, no reactions, but it's still on the allergy list. Take that off. That's not an allergy. You're just filling up this huge screen of allergies. The patients, they'll come in with 30 allergies. 25 of them are GI upset. So if a medication is not an allergy and somebody's documented somewhere, tolerated this in 2017, but the allergies listed from 2008, take it off. Okay? So take some notes, rewatch this video. Thank you for watching Lifelong Nursing videos. I'm Brent. Thank you for watching. This completes the video. Thank you for watching. Please be sure to subscribe if you haven't already and support Lifelong Nursing and everything we do. If you haven't already, be sure to watch the next video here and visit lifelongnursing.com. Thank you for watching.